And so it's a minute past the hour. We're going to go ahead and get started. A few housekeeping notes before we start the presentation. This webinar is being recorded and will be available to view from the UH Research and Education Institute website. Please mute your microphone throughout the presentation. If technical assistance is needed, please contact the Research and Education team, Nicole Bollinger or Abigail Zona Patel, who are on the call. If you want to ask questions, you can type them in the chat. Questions can be seen by all attendees, and you have the option to submit them anonymously if you prefer. For those who are invited to meet and greet session after the presentation, please remain on the Zoom upon the completion of the question and answer part. So my name is Igo Ofodokun. I'm the chair of the Department of Medicine here at UH and Case Western Reserve University. It is my honor today to introduce my friend, Danny, as our speaker for today's Health Services Research Center Distinguished Speakers Series. Dr. Fallin is the James W. Curran Dean of Public Health at the Rollins School of Public Health at Emory University, with more than 250 scientific publications that have been cited more than 30,000 times. Her globally recognized research focuses on applying genetic epidemiology methods to studies of neuropsychiatric disorders, including autism, Alzheimer's disease, schizophrenia, and bipolar disorder, and to developing applications and methods for genetic and epigenetic epidemiology as applied to mental health and development. She has also worked to promote the integration of mental health into the field of public health. Dr. Fallin has led multiple CDC and NIH-funded projects regarding how environment, behavior, genetic, and epigenetic variation contribute to the risk of psychiatric disease, particularly autism. She currently serves on the administrative core of the National Health, Brain, and Child Development, examining brain development from birth to age 10, with specific emphasis on how pre- and perinatal environment influences brain development. Dr. Fallin was elected to the National Academy of Medicine in 2023. Most importantly for us, she's one of us. She completed a Bachelor's of Science from the University of Florida, Gainesville, and earned a PhD in genetic epidemiology from Case Western Reserve University. The title of our presentation is Public Health in this Moment, Some Example from Autism Epidemiology. Welcome, Dr. Fallin.
Thanks so much, Igo. That was so kind. And I am really thrilled to be here. So thanks everybody who is taking time out of your day to be with us right now. As was said, I am a proud Case Western Reserve University graduate. I got my degree in statistical genetics and genetic epidemiology in 2000. This was for those of you old enough, this was the Hanging Chads election, was the time that I was leaving and joining Johns Hopkins, where I went right after my degree. And I did some work in something called haplotype analysis, which at the time was kind of avant-garde statistical genetics. Now seems a little cute 26 years later, 25 years later. And I worked with a fellow, Robert Elston, who was on the left, and Nick Shork, who was on the right, who were just incredible mentors and friends during that time. Because I know some of you from that time period of my life are still here in Cleveland and doing great work, I'm going to call out and embarrass one of those, and that is my friend and roommate on Hampshire Road in Cleveland Heights, Amy Kuntz-Kluge, who is Dorothy in this picture. That was Halloween 1999, but she is now a clinical research specialist working in the UH system. So hi, Amy, who's out there. And then you all know, most importantly, in my more recent life, Igo and I are cohort members. We entered the National Academy of Medicine in the same year. And I'll let you pick out which of the four of us is the coolest. Certainly the one wearing the sunglasses. So while my degree is in genetic epidemiology and statistical genetics, I really now characterize myself as an epidemiologist kind of writ large, because as I'll go through in just a couple of slides, I really think about all the different components that inform disease and health. And that means the sort of environmental epidemiology, genetic epidemiology, molecular epidemiology, et cetera. And it all came because, for those of you who I know come from many backgrounds who are watching this call, for me, this field of epidemiology is like such a cool juxtaposition of things I love. I love math. I get to do math. I love logic and sort of logic puzzles and that kind of thing. I certainly get to do that. I love biology. We don't do any of this work if we don't understand the biological plausibility and if it's not informing knowledge that would um, create primary, secondary prevention strategies. I love the complexity of it. And all of that seems pretty high-minded, but actually epidemiology and public health more broadly are very practical disciplines. And so I also like the practicality. And in this particular moment, I think it's also worth noting that, all of us who are doing healthcare and public health really approach these things, I think, almost universally with an honorable purpose and an eye towards the impact that we can have on our communities. And so while I trained in what's at the bottom of this picture, the genomic DNA kinds of science and discovery, what I learned very quickly in my career is that the molecular systems that inform our biology as humans, encompass so much more. And what I started to believe, and this is kind of the framework that I think about now as a molecular epidemiologist, if you will, is while the genome is incredibly, inherited genome is incredibly important, and I still think a lot about that in terms of a context of disease and health, what we know is the kind of central dogma, if you will, going from DNA to RNA to protein, all of those provide information. And in fact, in between some of those, the epigenetics, which is kind of control turning on and off, also provide information. And then lastly, at the top, small molecules like metabolites provide even more information. And what I mean by provide information is not only are they giving us mechanistic insights and risk insights, but if you go from bottom to top, this is really the extent to which these things are actually influenced by kind of above the skin or external factors. Whereas if you go from top to bottom, that's kind of the relative stability. So our metabolome or metabolite profile might change pretty dramatically in a given day, depending on what we're looking at. Our inherited genome will likely not change much at all. So why do I bring this up? Because when I think about how we use epidemiology and molecular epidemiology, this really encompasses being able to understand not only the biology of health, but also the social determinants of health, the landscape of change and what we can see in terms of prevention and intervention strategies on the biology from this top to bottom approach here. So that's how I got into this, thinking about, as a geneticist or a genetic epidemiologist, why would I care about environmental epi and other things as well? And in autism, which is where I've spent most of my career, the last at least 15 years, I was really intrigued by, while we can do genetics discovery and there's so much to glean from that, it's the environmental components and maybe some of the social components that afford us some real opportunities, because we have modifiability at individual, community, and even policy levels. When we're thinking about potential risk factors, many of the potential risk factors in autism on the non-genetic side are relatively prevalent. So even if they have low risk amounts in terms of relative risks, they can impact a lot of people, and so they can still have societal benefit. And so for me, this has kind of ended up with something like this, a kind of gestalt figure of there's a group of folks doing really incredible work in autism on the genetics discovery side. For those of you who do a lot of genetics work, both in the inherited and de novo worlds, and both in rare and common variants, there's just a lot of really strong work and a lot of insights that have come from that. On the environmental side, I'll talk a little bit more about why we've had some fits and starts in terms of doing environmental epidemiology in autism, but there's certainly been some advances there. And what I'm really interested in is bringing those two fields together and thinking about the interplay of genetic predisposition and environmental exposures together in ways that might manifest risk of autism or of the particular health experiences of people with autism. So that's a little bit about me, but the title of my talk is really about public health in this moment, and then my experiences in autism epidemiology that I think give some good examples of what we're facing. And so I hope you'll, bear with me and join me in thinking through these things together. So um, we are facing a tough time. I think all of you know this in academic public health, and I could say in academic medicine as well, although I'm a dean of a school of public health, so my frame is primarily academic public health. You all know we've experienced in the last year a multitude of executive orders, many of which have to do with healthcare, and public health. Um, lots of agency directives, lots of funding and personnel reductions, and then in the research world, a lot of grant terminations or non-renewals. And for us, as an academic institution, and I'm sure this is true for CASE and for university hospitals as well, there's been a lot of attention to how we manage just the legality and compliance of these things, how we manage the financial vulnerabilities of these things, how we manage the reputational loss. And here I really mean there's lots of ways you could interpret that. But for me, we do a lot of global health work. And one of the things that I think we as a field have been so proud of, certainly here at CDC, but also in academic medicine and public health, um, is our long-standing built trust with our partners across the globe. And that has taken years to build that kind of mutually beneficial understanding to survive some of the earlier days of colonialism in the way that we approach research across the globe, as well as public health practice. And we did that. I think we were really strong in that. But when you then drop funding and resources on a dime, that creates all kinds of mistrust. It certainly has also resulted in harm. And I worry about rebuilding that reputational trust and those mutually beneficial relationships. And then lastly, you guys probably experience this too. We're certainly facing, an uphill battle with morale that it feels like a lot of things are lost. But the work that we do, the people that we care for in the case of healthcare, and the people that we protect in the case of public health, those challenges are not going away. And we are needed, I would argue, now more than ever. Some of the things that I think a lot about right now are the research and practice areas that are particularly in jeopardy. This is still evolving, but some that we know about include health equity, preparedness work, climate work, LGBTQ health, vaccine research and work, and areas of HIV research. I said I'm a dean, so I'm not going to go through each of these, but some of the things that I think about very specifically are our early career scientists, our sort of funding mechanism for research, because I think research is so important for all of our communities and everything that we do, and the loss of our federal workforce. But what I'm going to talk about is really what I'm worried about as an epidemiologist living in this system. And so really thinking and could think with you all too in the Q&A about the consequences of misinformation, the emerging preventable health threats, the changing landscape of trust generally in science, in expertise, and in agencies, a simplification of ideas, and I hope I can give some examples of that. Remember, I said one of the things I love about epidemiology is its complexity, um, and certainly a loss of investment in health equity. So autism is going to be my example to go through some of those things that I'm concerned about with you all today. And so autism is an interesting story in terms of autism epidemiology, but really autism writ large. And this is a relatively new health state, if you will, in terms of being named as such. Really not until 1943 and 44 when Leo Kanner at Hopkins characterized something called infantile autism, did we have a name for this observation. And it then took a while before there was epidemiologic studies or other kinds of research studies. And then there was a lot of evolution of how we characterize, name, or label autism over the years. And then asking questions like environmental epidemiology or genetic epidemiology had some fits and starts. And I think it's worth saying just a little bit, I won't go into too much detail, but our first sort of environmental causal question or theory in autism was not a great one. It was an idea that this had manifest because mothers were too cold with their children, were not engaging with their children in ways that were productive. This is sometimes called the refrigerator mother theory. So you can imagine why when there was that kind of theory going on, there wasn't a lot of enthusiasm for other environmental work in autism for a long time. The next thing that was really a big highlight for environmental work that made international news is a fraudulent study that I'm going to spend more time on. Meanwhile, in the genetics world, we started having twin studies in the 70s, and then there was an explosion of genetic and molecular epidemiology that led to all kinds of discoveries in autism that have forged a way for understanding some of the biology in autism. So what I hope to do, and what I already said to you in terms of what I feel passionately about, is bringing those green and yellow fields together so that we can have the best possible knowledge base for autism moving forward. But one of the things that is meeting the moment I mentioned to you was kind of information and the consequences of misinformation or even lack of information. And so I mentioned one of the first environmental epi things to make the news in autism was a 1998 paper in Lancet that hopefully all of you who are part of the health and healthcare industry and environment would know about. And this was a great journal, but a really tiny study of 12 children, no controls, where they were looking at multiple conditions lumped together and mostly relying on parent recall. But it made a provocative finding that needed more investigation, that there may be a link between MMR and a suite of conditions, including GI issues, behavioral regression, and developmental disorders. So right away, many other folks, epidemiologists, got in this game and said, okay, let's look at this further. Let's try to ask and answer this question. I have no, at the time, and I think even now, we all think if there's a plausible question to be asked and answered, we should do it because that's what we do in public health. It shapes strategies for the future. But very quickly, other studies did not see the same kind of relationship between immunization and autism. And what also started emerging around that same time is that the timing might not be aligned. There was starting to be some building evidence that the pathophysiology that results in autism was happening likely in utero well before birth, and certainly early on, before what would be the typical time in which MMR and other vaccines are given. But it had immediate consequences. So this was in the UK. On the left, you can see the number of times that MMR was mentioned in UK national press across the years. And you see this big jump in the early 2000s. Remember, this paper came out in 1998. And then on the right, what you see is the correlative, I can't say that those cause each other, but the correlative reality that the percentage of children being immunized started to dip. And so we're seeing what lay press information about this looks like and what is manifesting in terms of choice for vaccination. And unfortunately, we also started to see increases in measles rates. And I put this in here not to call out Jenny McCarthy particularly, but to say that this was happening in a landscape where there was a lot of parent engagement and advocacy to promote the findings of this original paper. And there was a sense and a mentality that I just want to read to you because I think it's so profound and it explains a lot for the mindset which some parents are thinking. And she said at the time, if you ask a parent of an autistic child if they want the measles or the autism, we will stand in line for the effing measles. I think that's a profound statement, and I think it's really worth thinking about the passion and the energy through which some families were coming to this and receiving this information that came from a renowned medical journal. Unfortunately, what then became apparent within, this was 6 years later, was that the co-authors recognized that the claims that then were now being promulgated based on this paper were not supported by the evidence actually provided in that 12-child study. And so 10 of those 12 authors retracted their authorship of the paper in 2004. In 2010, the Lancet fully retracted the paper. And in 2007 or 2011, there started to be evidence of actual fraudulent or misconduct behavior, including that these 12 were cherry-picked, that there was an inconsistency between what was in medical records and what was in the research data, et cetera. And then unfortunately that there seemed to be a conflict of financial interest between Andrew Wakefield, who authored this paper, and some ongoing work with lawyers who were litigating against vaccine. Yet, what I think is the important part of the story is we continue to ask and answer this question. And so the epidemiologic inquiry into this continued with lots of investment because we, again, want to ask and answer important questions in public health. And you can see what's highlighted in blue is the number of people that are part of these studies is just mind-blowing, and really no links have been found in multiple ways and in multiple parts of the world looking at this. And there's a QR code there that would give you a kind of summary of those if that's of interest to folks. So what I often think about is like, what are the consequences of this story in autism? And there are at least these 6. First, the vaccine hesitation amongst parents for their children, which, as we saw in the UK and now we see in the US, has resulted in increased measles outbreaks, and that includes harm and unfortunately death in some cases. We see a continued mistrust in science that is much broader now than this particular issue, but I think we can learn a lot from this particular issue. A lot of funding that could have been spent on other areas of autism inquiry was instead spent on these refutation efforts over and over, as I showed you in some of the papers cited. I don't want to discount also the emotional distress. I was a pregnant mom in 2009 and again in 2011. This question was still kind of remember the refutation or the retraction didn't actually happen until 2011-ish. So this was still an ongoing consideration for a lot of families about whether you want to vaccinate your children and what that story is, and never as a parent wanting to be part of causing harm to your child. That's just a very emotionally fraught thing. And then the last 2 are kind of related. Distraction from efforts to examine other risk factors specifically for autism, and a diversion of federal funding for environmental epi that I think is related to this focus on the vaccine story. And so I'll say a little bit more about some of those things going forward, but we know, what has happened in terms of the mistrust and the vaccine hesitancy. Often what I get asked, and what I'm going to spend the rest of this time really on, is, so what does cause autism? Like, if vaccines aren't the story, what is the story? And so I'll tell you, it's not as concrete as we would hope. The thing that I can tell you for sure is that ASD is highly heritable. That means if you look at heritability data, which is on the right, and this is kind of the proportion of variability and risk for autism in a population that is due to the shared genetics of people in a population versus shared environment, really high. So really strong evidence that it's somewhere between 60 and 80 something percent, depending on the study that you look at. The study on the on the left is really compelling to me. This is Scandinavian data, and what it's showing is by age, so going from left to right, 0 to age 20, and going from bottom to top, the cumulative probability of an ASD diagnosis. And what you see, that low line is a little jagged line that reaches about like 2% by age 20. That is the general cumulative probability of ASD in this Scandinavian population. What you see in the gray solid line with the error bars, that's the same calculation, but if you only look at people who are a full sibling of someone who already had an ASD diagnosis. So if you are a brother or a sister of someone who had a diagnosis, that cumulative probability is enormously larger. And I hope you can all see that. So that's super convincing that at least familiality is a risk factor. And then the heritability question says, can we parse that between what families share in their environment versus what they share in their genetics? And it looks like a large portion of it is what they share in their genetics. And genetic discovery in the last 10 to 15 years in autism has been really incredible and has led to insights that are informing the biology of ASD and informing prevention strategies, particularly for profound autism and for specific kind of private mutation examples where where you can see the really strong, what we call penetrance of autism. But what that has left is a question about what about the rest of the variability in autism that may not be explained by specific genes. So I will get to that a little bit more, but let me start by then just going through some other demographic features that we know to be true that you can sort of take with that. What might that give us in terms of insight into causes or more practical public health approaches? So I mentioned family history. The next is male sex. No matter where we look in this country or in others, we see a very large proportion of boys versus girls or men versus women that are diagnosed. When we look at children, this is as high as 4 times, somewhere between 4 and 5 times the number of boys diagnosed than girls. When you start to look closer to adulthood, that evens out a little bit, but there's still a male bias in that. Parental age, not just mom age, which is what's on the top, but also dad age. So if we look at advanced parental age, across studies, we see increased risk for ASD in the offspring, for increasing ages at conception or delivery. In year of birth, this is a big one. We do see that the prevalence of autism, which I didn't even show you that picture, but we see that the prevalence of autism is increasing over time when you look at 8-year-olds in the US. These are European data, and you see the same thing. If you look on the right, age 0 through 20, this is sort of like the family history picture I showed you a minute ago, because it's the prevalence of ASD by that age. And then what you see is the birth year. So people who were born in 1980 are that lowest level where there was an increasing, accumulation by age 22. But the more recent years, like those born in 1991, much higher. You could do that in the reverse by looking at calendar year and birth cohort. Whichever way you look at it, it does appear that there's a secular trend to more diagnoses as the years have gone by. And then lastly, something really interesting called interpregnancy interval. This is the time between giving birth and conception of a new child. And if you look at these kind of odds ratios for autism, what you see is if that is somewhere less than 24 months, we start to see an increase in the probability that the offspring of that second or subsequent pregnancy will be diagnosed with autism. And this was a Keeley Cheslik Pastova's paper back in 2011 was one of the first to show this, but this is a really consistent finding across studies to this day. And I think of all those as kind of demographic risk factors. They don't tell us, a specific causal factor, but they give some inclination about thinking through how we might approach this problem. And then the last thing I wanted to mention was another demographic factor you might want to ask about is race and ethnicity. And there have been lots of data around this, mostly in the autism prevalence world. What we saw was if you look at 2017 data, which is on the top, if you look at in these particular data, the prevalence of ASD amongst Black children studied, it was 2%. And the prevalence amongst white non-Hispanic, it was 2.3. And this was seen as a kind of, would you interpret that means that there's some actual difference between autism risk in white children versus Black children, or is something else going on? And many in the field felt like what was really going on is a lack of access to diagnostic tools, to referrals and centers that could do that kind of work. And then there was a concerted effort made to narrow that gap. We could also see the same thing by looking at age of diagnosis, where Black children were diagnosed at a much later age than white children. That, again, is reflective of access. And so by 2021, those numbers had come closer together and, in fact, even reversed themselves a little bit. So I think it's really a difficult one to think through when we're talking about race and ethnicity in the context of autism, because so much of our data is dependent on administrative data sources or other kinds of sources where we know there's still disparity in who has access to care. So then if those are the risk factors in terms of just demography, what do we know about studied risk factors through autism epidemiology or etiology? And again, I come back to, we shouldn't be doing this in isolation. There's certainly been lots of discovery happening in the genetics world and some discovery happening in the environmental world. And now we're finally starting to put those two worlds together. And I already mentioned this, but I just want to reiterate, we have a focus in environmental epi of autism on the prenatal window because there has been evidence of what are now rarely used teratogens that did result in developmental disabilities. Those were exposures from the very beginning of fetal growth, converging biological evidence about fetal development and the pathophysiology starting, and very early behavioral differences even in the first year of life. So one of the challenges had been that study design had limited our ability to look rigorously at environmental agents in this critical window of pregnancy and very early life, but that has changed now. We, in my team and many others now, have access to pregnancy cohorts and information that's informing this. From that, we have had, we need to do a new one now on this, but we've had a couple of sort of cumulative environmental epi reviews in autism. And so this is a QR code for one of those that'll just give you a landscape of some of the information and some of the areas that we are actively pursuing questions in this domain. I already mentioned parental age and interpregnancy interval. I'm going to show you a little bit more about the maternal infection story, and I'm going to show you a little bit about the vitamins and folic acid story. What I can't show you today in terms of time is all kinds of other things where we are actively investigating. I'm happy to answer questions about whether the data are looking for or against these hypothesized risk factors, but these are all ones where there are now multiple studies. I'll give you sort of a spoiler alert, that SSRI one, we now think based on the epidemiologic data that has accrued that this is indeed not a risk factor, but the early associations were due to confounding, particularly confounding by indication. But these are active areas of research. So infection fever story. This is the kind of stuff you'll see in autism environmental epi. It's very different than the very large risk factors that you might see in a, in a Mendelian genetic example or in some other very strong risk factor examples. But as I said, often these are highly frequent exposures like fever in pregnancy. And so even if they have small increased risk, if it's happening to a lot of people, that can manifest in a lot of actual autism. So we pay attention to this. And what you see are kind of converging but not super, quote, statistically significant evidence. This one I brought up, though, to say that we do know that fever in pregnancy has other kinds of consequences that can be harmful for babies. So we do pay attention. And those of you who are obstetricians on the call may be thinking a lot about this. How do we prevent or mitigate fever and its consequences during pregnancy? And so this year it was really challenging to then have to manage information around an association between acetaminophen use in pregnancy and increased risk of autism. Most likely, those kinds of associations are because of confounding by indication. I just showed you there's evidence that fever itself may be a risk factor for autism. And so if one is treating that fever, those two things can be conflated. Emerging evidence, even as we speak, has seen that if you can do things like sibling-controlled analyses, we don't see that association anymore. If you also try to take into account fever, you may or may not see those associations. So what I would say is that's ongoing science, but it's tilting towards there is no association at the moment. And for those of you who are practitioners, there's a lot of good reason to continue to provide access to acetaminophen in pregnancy when it's warranted. And then the only one I was going to pick out was folic acid story because I think it's kind of interesting. So much like neural tube defects, we see over and over again when we do autism epidemiologic work that there is a preventative effect of taking folic acid supplements or multivitamin supplements containing folic acid during pregnancy, primarily around the conception time. So really periconceptional exposure to supplementation. And so when you think about that, it means that it's a risk to not have enough folic acid in the system, right? So another way to look at this would be to look at the amount of folate that is available or that is measured in moms or in babies during pregnancy. And the reason I show this paper, which was one that I was a part of, is if you look at the top, if we have a reference of sort of an adequate amount of folic acid supplementation, what you see is if you don't have enough supplementation, that's a risk. That's the same thing as saying there's protection because of supplementation. But what we saw was actually if you have very high levels of supplementation, there may also be a risk. And this kind of was provocative of a question, is there a U-shaped curve to this? And so if you look at the bottom, if you measure not supplementation, but actual maternal plasma folate levels, we kind of see the same suggestion of a potential U-shape, that really low levels are not good in terms of risk for autism. Really high levels may once again be not good. But more work is necessary in this particular space, because we know that there are genetic risk factors for clearance or other kinds of metabolism of the folate pathway and supplementation of different kinds. There's also fortification happening. So this is a complicated story that doesn't have a simple answer. And then I'm not going to go through any more of them for you, but I just wanted to highlight the other very consistent finding in autism epidemiology right now is air pollution. So exposure either to near roadway air pollution or to measured air pollution using monitoring systems, particularly in the US, but also in other parts of the world, seems to show increased risk for ASD in the offspring for exposures happening kind of in mid to late pregnancy. What is unknown is what are the components of that air pollution, or still could that be confounding because of other social determinants? So a lot of work still going on in that domain, but very consistent findings. So I just wanted to end by saying, the consequences that started with this story around vaccines and autism continue. But one of the things that I think is a place for optimism is I mentioned the distraction from efforts to examine other risk factors and the diversion of federal funding for that kind of research. That is changing, and it's changing in many ways, but I'm happy to say that we are one of 13 new studies from the Autism Data Science Initiative to be examining at scale the full exposome, the full kind of small molecule evidence for exposures that may further inform autism, particularly in pregnancy and very early life. So maybe, one outcome of this is that we are getting some more attention to other non-vaccine aspects that still need serious attention and questions to be asked. And then I'm going to end with you on where I started with the mistrust in science, because I think it's on so many of our minds. And I'll just brag a little bit and tell you about something that we're doing at Rollins, if you'll forgive me for it. And that is, we take this very seriously, and I'm sure you do as well, that we need to be a trusted source of information. But when you think about that in a science communication framework, to do that well, it means we have to not be judgmental. It means we have to give information that is understandable, and we have to entertain. It has to be something that somebody would want to listen to. So we have this live show that's right now locally in Atlanta that happens for an hour right before Science Friday on our NPR station called Health Wanted, that then is published as a podcast every Friday. And we're really excited. We've been doing it for a year every week, and we have downloads in over 130 countries and in all 50 states. And we get a lot of positive feedback. And this year, public radio and the national level has taken this on. And so it may be coming to your local NPR soon, starting in January, depending on who picks it up. But the real point to that is we need these new mechanisms of sharing quality evidence-based information, but that are meeting our communities where they are. On the left, there are many other people thinking about this. We could have a whole conversation about other academic medical societies and schools. I would highlight the Association for Schools and Programs of Public Health, as well as the de Beaumont Foundation, who are thinking very much about these ideas of easy to understand, entertaining, meeting people where they get their content, and partnering in innovative ways. One thing that's not on here that I will say, if you'll forgive me the 2 seconds for this, we did a Gallup poll, and many others have seen the same thing. The most trusted source of information for most of our neighbors in our communities across this country are our healthcare providers. So you all listening, many of you who are healthcare providers, you have the opportunity to be this trusted source. And the real challenge is, how do we give you the talking points and tools and skills to do that in a way that fits into the schedule and the relationships that you need to maintain in the work that you're doing. So we've been thinking about this from a whole bunch of ways, not just that one-way science communication, but also how do we build skills and dialogue that will allow for this. So This moment in time is challenging for a lot of reasons. I hope I've acknowledged that and named that, but also I think is an opportunity for us to listen and build bridges. We've seen from the autism example how things can get out of hand, but also how if we listen to folks and sort of meet folks where they are, we can move forward in areas that are actually rigorous investments in really important questions. And so I hope we all kind of take up the mantle in this new year to focus on the many opportunities that still exist to shape what's next and to really bring back our enthusiasm for the work that we do in public health and in medicine. So thank you. And I'll leave it there with my autism villagers.
Thank you so much, Dr. Fallin. This is really, really informative, and a couple of questions on the chat, and one of them from me was just really wanting to know if there's ever going to be a time through advancement in genetic screening when we can predict before a child is conceived whether a parent has a risk of birthing an autistic child.
Yeah, Ego, it's a good question. It's a really fraught question, and it's one that folks in the neurodiversity community are very concerned about. Because they see this as an affront on their very existence. The idea that if I could test while I'm pregnant and know that my child is going to have autism, would I make decisions that might terminate that pregnancy? And that is a really fraught question for a lot of folks. The Downs community, other communities have had these same kind of discussions over the years. And there are folks on both sides. There are folks who are families of profoundly autistic individuals, who really are interested in understanding these causes because there might be things that we can do to prevent that very serious disability that exists in those folks. But a lot of the neurodiverse community sees that as a threat to identity, right? So that's why I want to shape my answer to you. So with that said, will we be able to predict certain autistic outcomes based on genetic screening? Yes. The reality is, what are the ethical considerations around doing that as we move forward? And so we could have a whole separate conversation about what we know today, what we think we might know tomorrow, and how we would best use that information to empower our autistic community to not have to experience some of the challenges they face in their health throughout a lifetime without it becoming an act of prevention of the life itself. And I hope for those of you in the neurodiverse community who love someone in the neurodiverse community who are on this call, feel free to also weigh in maybe in the chat about this, but it's a really fraught and difficult topic.
Yeah. There's a question here from Stacy Miner. So I was really intrigued by the finding about the increased rate of autism in children conceived shortly after a previous birth. What are your leading hypotheses that could explain that elevated risk?
Yeah, I mean, I'll yield to any of our obstetricians or maybe even some of our pediatricians and neonatologists to answer these questions. But there's no one prevailing theory that I know of right now. There have been folks wondering about the immune cascade of a mom as she's going through recovery after birth before the next conception. There are other kinds of molecular recoveries going on in terms of returning to a sort of steady state. And that if that hasn't happened yet, that may create suboptimal environment for the next pregnancy. This interpregnancy interval has been shown for other neonatal outcomes. So there are folks who may know, including Ego I'm looking at, but there are folks who may know more about what some of those biological hypotheses might be, but it's really intriguing because it's so consistent in its finding.
Thank you, Danny. Another question here from Suda Linga.
Oh, yeah, Suda, I should have put your picture up too.
Love the presentation. Would you be able to say something about whether increase in parental care and increase in survival of infant may also increase the risk of ASD?
Yeah, so say that again, Ego, because I'm afraid I want to make sure I got it right. The increased age, say it again, because I'm not sure I understood it
So would
correctly.
you be able to say something about whether increase in parental care, prenatal care, increase in prenatal care and increase in survival of infants may also increase the risk of ASD. So
Yeah, so it's a
everybody that is
really,
born is surviving. Could that
right.
contribute into the increase?
It's a really important question, and I know Mark Weisskopf at Harvard and a couple of other autism epidemiologists are continuing to think about methodologic ways to accommodate that possibility when we do these kinds of epidemiologic studies. Because you're right, there is a bias that we're not capturing in terms of survival to birth that could be problematic in interpretation of some of these findings.
There's another question here from Stephen Goodrich. So it says, can you discuss how the newer autism subtyping will direct research into the genetic and environmental etiologies and perhaps ultimately treatment studies?
Yeah, so I'll have to read in a little bit to your question, but when there's a couple ways you could read what autism subtyping will mean. So there's a group of folks thinking through autism subtyping that's molecular subtyping that would be about either, a very frank one would be if we know the genetic cause because it's a private mutation in a particular family, all the way to some small molecule or other kind of subtyping that would be based on kind of predictive information. And then there's behavioral subtyping, which would be what we've relied on, since the 40s when we started classifying autism as its own outcome. And that has changed over time with the Diagnostic and Statistical Manual, or what we call DSM. Most recent one was 2013, so it's been a while now, but there had been a lot of change in a short amount of time. So I'm not sure which of those you mean, but I want to give that landscape of the behavioral subtyping versus the molecular subtyping. I think there has always been hope that that is useful for both etiologic and intervention studies, because one can imagine that there might be different etiologic paths to a particular form or presentation of autism. So that is ongoing. And you can imagine how that might be true also for treatment. So someone that is, their primary health complaint as an autistic person are persistent GI issues, that the approach for that person might look very different from someone whose primary health challenge is self-harming behavior, right? So clearly there would be reason to have a distinction in those subtypes.
Thank you so much, Dr. Fallin. In the interest of time, we're going to round this up. And just to remind you again, this presentation has been recorded and will be made available to the general public through the UH Research and Education site. This has been extremely very informative, Dr. Fallin. Thank you so much. We appreciate you doing this. And we're going to round up this session of the presentation and go into the meet and greet session. And so if you have been invited, please stay on. Thank you so much. See ya.
Thanks, everybody.
Yeah. Bye.